All right, I think we'll go ahead and get started. We'll have lots of time for some flexibility and questions and everything. I'm Brady Evans. I'm one of the hand surgeons here at Stanford and part of the value-based care program within orthopedics. So over the last year and plus, there's been a lot of work collaborating with primary care. I've talked to several of you about that. So we're very happy to have organized this, get a lot of you here. Hopefully, it's worthwhile and worth your time. I think some others will probably trickle in as you go. Feel free to get up and eat, use the restroom. There should be time for that as well. So some of the goals for the evening, our plan is to kind of take a step back to basics, go through presentation, physical exam, history taking, mostly focused on knee, spine, shoulder issues. If there are questions about other body parts too that come up in relation to that, I think one of us can probably answer as well. We'll go through some of the maneuvers and hopefully have some time to practice, and then try to think about things that would prompt further evaluation, either referral to one of our orthopedic surgeons or PM&R colleagues or further imaging. And then some red flag symptoms, things that you might want to bump up to emergency room right away. I'm going to turn it over to Dr. Okiki for a minute to go over a couple other things, and then I'll kind of go through our agenda and get it started.
Cool.
Go ahead.
All right. Well, thank you all so much for being here. I am so excited to see everybody in person. This is completely amazing. For those of you who don't know me, I'm Jessie Okiki. I'm family medicine in primary care population health, and my practice is in the employer-based section. And I just want to take a quick moment and acknowledge the value-based care projects. This is an amazing platform that has brought together orthopedics and primary care to really rethink how we're providing high-value musculoskeletal care and what we can really do to make sure that our patients are getting the right care at the right time in the right way. So the reason we're here is that over the course of a couple of years and a couple of rounds of qualitative interviews, primary care doctors again and again, and APPs again and again said that when they feel confident in their exam, when they feel confident in what they see in the patient, they feel better able to direct patients to the right place for the next step in their care, and they feel better able to reassure patients that they don't need care that's not going to change the course of their management. So hopefully, we'll feel a little bit more confident at the end of this this evening. I do also really want to thank Dr. Hu and Dr. Sherman for coming out and spending this time with us. It is amazing to see you guys. You've taken such care, wonderful care of so many of our patients. It's absolutely incredible to be able to learn from you guys directly. So thank you. And I also really want to thank everybody from primary care who came out tonight. This is very exciting. We also have some people who couldn't join, and so we are recording this session, and we will be making it available online for virtual CME as well. All right, I just want to highlight briefly that we have some care pathways that were developed in cooperation between radiology, primary care, and orthopedics, and vetted out by a lot of your colleagues. You'll see a lot of names you recognize at the bottom of this slide. We have them online on the websites here for spine care, for knee care, and for shoulder care. And if I go one more, this QR code should take you to the website. So if you just aim your phone at it, then you will have the website loaded in for yourself in case you need to access it during your clinic.
And we'll have that up at several times throughout, and it's available on paper too. So if you don't get it now, don't worry.
Yeah. So that's all for me.
All right. We have a pretty loose agenda for the evening, so we're going to start off focusing mostly on spine. So I'll introduce Dr. Hu in a minute, but we'll go through spine evaluation and exam and then follow it up with some time for discussion. And my hope is that we'll get a chance to practice. I wore scrubs, so if anybody needs a guinea pig, we can do that. And Dr. Hu will be available to go through some of those things as well. We'll take a little break. Like I said, feel free to grab food in the middle if you need to, use the restroom. And then Dr. Sherman will be heading over. He's taking care of some of the Stanford athletes at the football clinic, so he's going to be a little bit later, but he'll come do the second portion where we'll go over knee and shoulder, and then the same sort of format where we have a chance to ask questions and practice. I put my contact on here. I'll also have it up at the end. If anybody has questions about the session, referrals to orthopedics, or is just trying to get in touch with somebody and is having trouble, I'm happy to be a contact or a go-between. That's my cell phone number. I'll also have it up at the end. So to kick us off, I'll go ahead and introduce Dr. Serena Hu. She's a professor and vice chair within the Department of Orthopedic Surgery and Neurosurgery by courtesy. She's very well known in the field of spine and orthopedics, is a recent past president of the American Orthopedic Association, and someone who a lot of people go to for questions, and I'm sure you have shared many patients with her. So I won't waste too much of her time introducing more. I'll turn it over to her and get started.
Thanks very much for coming. I recognize a lot of familiar faces and names, so it's good to see you in person and have a chance to share some of our secrets. They're actually not secrets. They're really pretty basic parts of the exam, but I think some of it's just repetition and feeling familiar. Can you guys hear me okay? Is this on?
So that's only for recording, it's not for the room.
Oh, so I have to actually yell? I'm really bad at, like, speaking, so I'll do my best. But if at some point, if I kind of fade away, just tell me to do this or whatever, because I am better at, like, in a small clinic room. So anyway, so I'll talk a little bit about the spine exam, and part of what I'll be going through is kind of the basic parts of the exam. I don't have slides on this, but obviously the differential is part of it too. And just raise your hand if you have questions. I think it's easier to kind of address them as we go along, so that you can see, and we might or might not have pictures associated with that. So, like everything, the history of the present illness is probably the most important part when the patient comes to you. You want to know how long they've had the symptoms, whether it was acute, whether it's kind of acute on chronic, whether it was a triggering event or something that seemed to bring it on. A lot of things we have, people, they're sort of acute on chronic, but they attribute it to something, for example. So that's kind of useful from the standpoint of knowing what they might avoid, for example, when you're trying to treat them. And then if they have any functional problems, for example, so if they find that they can't they can't sit at work anymore, they can't stand at work, whatever it is that they're doing, if it affects their function, that's really important from the standpoint of how they manage and that kind of thing. And then, of course, the treatments they've tried. It could be very simple, like rest or ice, could be anti-inflammatories, it could be avoiding certain activities, and some of them, stretch or move a certain way to try to do things or change positions. And that's important from the standpoint of our differential and trying to sort out what is causing their problem, and therefore how would it be addressing them, as well as part of the workup. So a lot of these people have a prior history of spine complaints or extremity complaints. They might have had an injury, they might have had prior surgery. There's certainly a lot of medical conditions that can be relevant, such as rheumatoid arthritis, ankylosing spondylitis. There are a lot of neurologic conditions that can be coexisting, such as MS or Parkinson's or myasthenia. And certainly a patient who has a history of osteoporosis or osteopenia or fragility fractures, indeed, is important for us to know about. So ask those questions. They're all part of, relevant to the musculoskeletal part of it. And then red flags, of course. So anybody with a history of a malignancy, we all know that's, you have to watch out for that being another cause of whatever pain that they're having, whether it be metastatic or fracture or a tumor, and certainly any systemic symptoms like a history of weight loss or loss of appetite or night pain. These are all things that are red flags from the standpoint of could be a sign of something more dangerous than just having an orthopedic problem. Not that orthopedics isn't important, but something that is more life-threatening or functionally threatening. And the other risk factor is just the age over 50. The older you are, the more likely you are that you would have had something that's related to a tumor. So age is also a relevant history. Any questions so far? Okay. So when you look at the patient, and I'm sorry, I meant to put some pictures in here and somehow they didn't make it here. So I look at see a lot of patients with scoliosis. So when we look at their back, we look at the symmetry of are most of you guys primary care doctors? Anybody here a physical therapist? Okay, so the physical therapists like this a lot. But so you look at like their shoulders. If their shoulders are level, that's relevant. Their waist might be asymmetric. That's relevant. If you, some of you know that with, remember when kids do a forward bend in junior high and high school, you look at the asymmetry of their back, and that might be a sign of scoliosis. So scoliosis, as you probably know, is not just the x-ray that's a curve from side to side, but the spine rotates as part of the scoliosis, and that's what gives you the asymmetry. So those are the kind of things that might be relevant, that the right the right thoracic curve is the most common curve in scoliosis, so their right scapula might be a little bit higher, okay? And the left lumbar compensatory curve is the second most common, so the left lumbar prominence or rise is the other term we have for it, and that might result in their waist being asymmetric. So this isn't a common condition, but it's something that's very easy to diagnose visually if you're paying attention to these things on their patients. So it's very, very easy to kind of notice. Of course, if a patient has prior surgery or prior incisions, it's relevant, more for us to know, but it's certainly, sometimes they forget they had their spine surgery when they were a kid because it was a little operation or something like that. And then the presence of cafe au lait spots. Does anybody know why cafe au lait spots are relevant? Exactly. And why is that relevant for orthopedics? They have a high incidence of scoliosis, as well as a lot of other related other orthopedic conditions. So that's something that it isn't very common, but you know, it shows up every so often. You get to look really brilliant when you identify it. It's like, you got those cafe au lait spots. You have this history of these little tumors, and like, how did you know, doctor? Anyway, and so after inspecting the patient's back, I usually ask them to tell me where it hurts. You know, they oftentimes have a pain diagram, but it's helpful to actually have them show you on their back. And you can see, is it a tender area? Is it red at all? Maybe they had a surgery there. Is there a prominence there? So these are the kind of things that while you're looking at their back, even though you've got their pain diagram, it's nice to have it relevant. And, you know, even though we get a lot of information from those questionnaires and things like that, the patients don't necessarily understand, hey, we already looked at that. They want to make sure you know all of their problems. So, you know, kind of, okay, your pain is here. I saw that on your pain diagram. Is this what you mean? Those are the kind of things that are really very relevant from the standpoint of understanding. And some patients will say, well, it's in my hip. But where they say there's their hip, is it here or here or here? So exactly how they're describing their symptoms versus how we understand it anatomically is obviously relevant to understanding where their symptoms are coming from. So the next thing I usually have them do is to walk. Okay, very simple thing. And obviously in orthopedics, that's really important. And they might favor a side. They might limp on some side because it hurts or because they have weakness, and that's relevant to note. And then they might not be able to stand up straight because they have spinal stenosis or because it hurts. Or they might lean one way or another because if they have a herniated disc and they're trying to lean away from the disc, it's called a sciatic scoliosis because they're trying to have less pain. And those are all relevant to the physical exam and kind of tell you a little bit more about where their pain might be coming from. And then part of the neurologic exam is seeing if they can toe walk and heel walk, because as we'll get into, you know, it's fairly easy for us to do what we call manual muscle testing. So if you like have the patient move their foot up and pull them up and try to resist that, okay, they might have what you think is pretty strong, all right, but your hand isn't as strong as what they have to do to walk around. So it's more relevant if they can't walk on their heels or can't walk on their toes. So they might have full strength in ankle dorsiflexion, but they might not be able to walk on their heels. Same thing with toe walking. You know, they might be able to push hard down on your hand when you're examining them, but if they can't walk on their toes or do toe raises, that means that they have a deficit of their strength relative to what normal should be. Okay? And then the other thing I do besides toe and heel walking is have them walk. Depending on your viewpoint, you can have them. I have them walk on a tightrope, but some patients look at me immediately and say, "Oh, the sobriety test." So it kind of depends on what their experience has been, but that's a sign of balance. You know, so if you can do a toe heel walk well, then you have good balance. Okay, if you can't, then you have to start worrying about ataxia and myelopathy and other causes that they might not be able to toe heel walk. Okay, so let's see here. Yeah. So the sensory examination, it's not as important for you to memorize these different areas. So you guys probably may or may not remember from medical school, we have little dermatomes, what my PA calls dermatome man. And so C4 is up here, C5 is here, then C6, C7, T1, and then up into the chest. And so those exact details are important. But if the patient complains about numbness from here down, as opposed to along a dermatome, okay, then you're sort of more thinking in terms of how does it fit into a spine exam. If they have pain or numbness from the wrist down, you're thinking, let's call Dr. Evans because they might have carpal tunnel syndrome. That's not usually radiculopathy. So the pattern, you know, again, remembering the exact roots isn't necessarily important for you to think about because you're thinking about who to send them to, but does it fit a dermatomal pattern or a peripheral nerve pattern? Okay, and so that's kind of more relevant to that. We pay a lot of attention to does their symptoms match where they are, what the MRI shows. Like if they have a big herniated disc at C4, 5, but their pain is in a totally different region like C7, we're like, something's wrong with this. This doesn't account for this. But that's, we have to do that for you. It'd be nice if everybody knew everything and stuff like that, but I don't know anything about, cardiac disease or hypertension or anything in those. So I'll leave that to you guys, and, we gotta leave us something to do. So anyway. Anyway, so those are the important parts. Light touch is obviously the easiest thing to do. You can get into pinprick, which is different from light touch because the columns that travel down the spinal cord, but you don't have to worry about that. It's really, do they have a sensory deficit, or are they hypersensitive? Okay, if you're worried about posterior column, you might want to think about vibratory. Does anybody still have a tuning fork around? Do you use it? Okay, so what have you picked up with your tuning fork?
I've used it kind of with the diabetic, but again,
Okay.
just
Yeah.
illustrate to patients.
No, that's great.
their decreases.
That's great. No, I mean, it's actually a really, if you can notice a deficiency in vibratory sense, that's posterior column or diabetes or TABIes and things like that or whatever, that's a really good pickup to do. Sometimes we don't have enough time to do it, and it doesn't pick out as many of my patients as you sometimes see, but to have it as part of your armamentarium is really, really important to have if you can. And then for the lower extremities, again, so starting at the groin, so remember that the thoracic spine has different levels. T4 is the nipples, I think it's T12 is the umbilicus, and then L1 is, and T12 are just by the groin. And then as you follow this down, there's different regions. So if around the knee is L3. So sorting out if knee pain is from the knee itself versus L3 is part of what we need to do as part of our differential. Patients who complain about this, it's usually their knee. Okay, I don't know if you guys, so it's like, this is my knee, okay? But if it's this whole area, is that L3? Okay, so it's part of what they gesture, and then again, and you have to examine the knee too, and look at spine exams and things like that or whatever. But you get a lot of hints just from what the patients are pointing to and how they're pointing to them. And then the medial calf is L4, and I'm pointing these out because these are the most common levels. L5 is lateral calf, and then down the front, because the first web space is L5, you may remember, and then the lateral foot and the bottom of the foot is S1. So these, and then the sciatic regions, as people point to down the back of their leg. Okay, so again, it's just important to kind of understand where their sensory deficits might be, and this oftentimes follow where their pain might be. Okay, any questions on the sensory exam? Okay, am I being too basic? Oh, yeah.
Do you ever use position sets instead of vibratory sets?
That's probably easier if you don't have a hammer. I mean, a tuning fork. Definitely true. And it's interesting because I found that patients who have numbness often complain about difficulty with proprioception, but it's not real proprioception. It's, so they can still tell where their foot is in space, but they still have a harder time, say, walking. So peripheral neuropathies, oftentimes, they're like, I can't balance. I'm like, really? You just have peripheral neuropathy, but they can't feel where their feet are touching down. It's kind of fascinating. I don't think they taught me that in med school. I don't know about you guys, but anyway. Okay. So the reflex exam is probably where you guys may have a little bit more question about exams. Did everybody carry a reflex hammer with them on their exam or have them in their rooms? Yeah. So the exam basically involves, basically tapping the tendon that you're testing, and you should get a response, of course. So the wrist might be right here at the brachioradialis, and you should get a little flicker. Now, if you have you can sometimes get a really brisk reflexes, like at the bicep, like it jumps. Okay, that's obviously pathologic. I'm not sure if there's a good way to grade them. Like 1 is a little one, 2 is a big one. If it starts really jumping, you're just like, this is hyperreflexic. I don't know if you go to 3 versus 4, but that's not right. Okay, and then you start looking at pathologic reflexes like the Hoffmans and the Babinskis here. But there's a cross-radial reflex, so you can kind of tap the patient's brachioradialis, and the other hand jumps, or even their hand starts kind of grabbing, like almost like a Hoffman's. So it's kind of a spread, and those are obviously relevant from the standpoint of myelopathy. So remember, my long track signs are when you basically have a lack of inhibition from the top because they've got spinal cord compression. Okay, so if you have hyperreflexia or these hyperreflexic abnormalities like Hoffman's and Babinski, like I'll get to in a second, you've got to be wondering, this isn't just the nerve root, okay? This might be the spinal cord itself. And one of the common things that I see is a lot of patients present, I'll get to this a little bit lower, but I'll get a lot of patients who will present with back pain, because a lot of people have back pain. And then the kind of common response for all of us is that they have back pain is to get an MRI of their lower back, especially if they complain about weakness. But a more common place to have spinal cord compression, especially if it's like a tumor or an injury, is actually the thoracic spine. So it's surprising how many people, may, and this obviously isn't everyday occurrence, but I'll see people that come to the emergency room where their doctor has said, well, they have back pain and they have leg weakness. The MRI of the lumbar spine is negative, but they've got a tumor in their thoracic spine. And it's just like paying attention. Well, wait a second, this person actually has hyperreflexia. That isn't going to be from L1 down, because that's your cauda-equina. That isn't going to give you hyperreflexia. So kind of understanding a little bit more about that and paying attention, I think, will help a lot from the standpoint of, the cases that I've seen. A couple of them have had missed the diagnosis because, they didn't think, well, wait a second here, this person has weakness. It's not accountable by their lumbar spine. Let's look higher, like the thoracic or cervical spine. Okay. Anyway, so the symmetry of the reflexes is probably more important because there are a lot of people who have muted reflexes. There's some people that have fairly brisk reflexes. Hopefully people know that a couple beats of clonus is normal for a lot of people, especially in kids. Okay. So the Hoffman's reflex, do people know how to do that? Remember how to do that? That's one of the harder ones. So, okay, who wants to be a guinea pig? You want to do it? Demonstrate?
No.
Oh, you want to be the guinea pig?
No.
All right. I hope you don't have a Hoffman's, otherwise we're really going to be in trouble. Okay. Hi, thank you. Okay. Sure. So what you do for Hoffman's is you want to hold the wrist sort of at a neutral position, just a little bit of dorsiflexion, okay? And then you want to let her relax and then flick the nail of your middle finger here. Okay, and if it's a positive Hoffman, your fingers will flick in like this. Okay, so it can be pretty subtle, and part of the key is to make sure the wrist is relaxed. Okay, and flick it just enough. Okay, and thank God you don't have one.
Right, and then
you would do like we did divine. So I would do like this.
Okay, and this way. Okay.
Yeah. The thumb is the most important one, but sometimes you get this one that just flex in a little bit. So it can be pretty subtle. And again, you got to make sure the wrist is relaxed and just flip the nail. Okay? So you guys can practice that later. And Babinski is probably more common for people to remember. So you remember how to do the Babinski? I'm not going to have somebody, I'm not going to have somebody stick up their somewhat smelly foot. But yeah, so you take the, like you can see the picture here, you'll take the back of your reflex hammer, and like you were saying, you come up the lateral side and come medially. Okay, and then what should it do?
Correct.
Pardon? Should go down. Exactly. So if it goes up, it's upgoing toe, and should not be that way. Sometimes you can't tell, and you can just call it equivocal. But if it goes up, it's pretty obvious that it's, and sometimes you got to be careful because obviously people are ticklish. So you have to watch carefully. You got to watch carefully because it'll go down first. For a normal person, it'll go down first before they withdraw. So you got to kind of notice the down first, which is normal, before they withdraw because they're ticklish or in pain. Okay. Any other questions on pathologic reflexes? Those are probably the main ones. Okay, great. So muscle grades. This is a little bit subjective, but you try to have consistency. And so when I'm following a patient after a spinal cord injury, for example, or after a surgery where I'm worried about my neurologic exam, it's very important that the same person is doing the exam. Okay, so you have some consistency. But the muscle grades are 0 through 5, as you probably remember, and obviously 0 is nothing and 5 is full strength. But like I mentioned, full strength against manual muscle testing is not the same thing as full functional. Okay, so the person might be able to kind of push down on your hand, but they can't walk on their toes or even push off. That's not full. The other thing is so the other standard between the 0 and the 5 is 3, which is against gravity. Okay, you guys all remember that, right? So 3 is if you can resist against, you can, do the motion like, say, extend your knee against gravity. And if you can't, and you have to remove gravity to get it to work, that's a 2. But to be a full 3 should be against gravity through the full range of motion. Okay, so you can have people that can lift their leg, but they can't do it in certain positions, or they can only do a little bit. So that's not a full 3, that's a 3- or even a 2+. Okay, so these are important, partly again internally, but also to let you understand better the kind of subtleties of your exam, so that when you're documenting, you can understand, where you want to put somebody, for example. Okay, and then 4 and 5 are pretty subjective things because, I can overpower hopefully most old ladies, but there are some football players that I can't. Anyway, so they're a little bit more subjective, but again, the full strength, and some of it is just, really full strength is being able to like squat and stand up, which we don't test normally, but sometimes if I want to test them fully because somebody's complaining, well, I get tired at the end of a day and can't climb stairs, it's like, okay, well, that isn't something I can't, that's gonna be harder for me to detect on my manual muscle testing, but they can't squat and get up. That's a more physiologic test from the standpoint of full 5 out of 5, okay? And so, so accordingly, you have all these muscle groups that come out at the different levels here. And again, these aren't necessarily ones that you have to memorize exactly, but deltoid is C5, and biceps is also can be C5, but there's some overlap. Triceps is C7. So again, the more important thing for you to remember is where are they weak? Do they make sense? And we can help sort that out. So these are the groups that we typically measure: is the deltoid, the biceps, the triceps, wrist flexion, extension, and the intrinsic. The intrinsic is another one which is tricky because we do this, and guess what? We're a lot stronger than most people's intrinsics. So sometimes we try to tell people to test against your own intrinsics because we can overpower most people's intrinsics. Okay. I think these slides are going to all be available if you guys, so I don't think you need to worry about pictures, and they'll probably, depending on your angle, it might or might not be available. So the lower extremity also has kind of typical areas that we test. So we do iliopsoas hip flexion, which is L1-2, and then extending the knee is usually L3. The quadriceps, and then we go to ankle dorsiflexion, L4, EHL is L5, plantar flexion is S1, and again, for some of the S1s, I have to pick up a difference. I have them do single leg toe raises compared to the other side to pick up a difference, because it's a really strong muscle. Okay. Other question? Yes, please.
I have a question about upper extremity. I
Yeah.
typically just do the pronate or drift for upper extremity strength, and if that's abnormal, then I go through the different muscles. Is that a good approach, or would you go through the different muscles right away?
I go through all the different muscles right away because I'm trying to localize the root, okay? But you don't necessarily have to do that. You have to kind of sort out, do they have a problem that I should be doing an MRI of their neck, for example? So that's a reasonable, good screen, but from the standpoint, because again, what I'm expected to do is figure out whether or not they need surgery or something like that or whatever, and interpret the MRI. You're trying to decide whether to do the MRI.
Right.
So, yeah. Yes?
So I still do a fair number of video exams.
Mm-hmm.
And for lower extremity strength, I can squat, stand on their toes, stand
Mhm.
on their heels. Do you have any thoughts on upper body strength on camera?
Okay, so actually that's interesting because one of my partners in physiatry actually has them get soup cans. Okay, so you can have them get a soup can or a water bottle and lift those, and compare left versus right, because that's usually the most obvious thing is, so, can you do this with your soup can, and can you do that with the other soup can, and then the same sort of thing with deltoids, can you lift them up this way? So is that helpful? I mean, I think that we find that the soup can idea or the water bottle, again, is something handy around the house. They can grab them, and it gives you an idea of real, some strength involved, and you can compare the symmetry that way. Okay. Who's still doing a lot of video visits for? Okay, yeah, and I think it's here to stay. I try to do new patient evaluations in person just because you just get a feel for things, but sometimes it's not possible, and sometimes you need to know whether or not to pull the patient in person for a personal visit. So these are good screening exams to get an idea of how is there really a difference between one versus the other, because that's the most common presentation is not symmetric but a unilateral deficit. Good question, thank you. Okay, and so then we have provocative tests. And so are you familiar with the Sperling's test? I see a lot of nodded heads. So the idea is if the person has nerve compression on one side from a herniated disc or foraminal stenosis, is to try to close down that space and see if that reproduces their pain. Okay, so it usually involves kind of turning it to the side and extending a little bit and then putting compression on their head. Now, this picture says that it's 92% specific and 95% sensitive, and I gotta tell you, I am the world's worst Sperling's test doer. I cannot do this test. I mean, I'm like, the resident goes in there, oh yeah, I got one. I'm like, okay, and I go and I can't get it, and I'm like, can you have, I'm just terrible at the Sperling's test or whatever. So if you can't do it, you're in good company. What I do find helpful is that one of the things is that if they walk around like this, they almost always have a cervical root, relieving the nerve, just because the root kind of comes in underneath it, and if they lift up their arm to take the pressure off, it's almost always a cervical herniation or whatever. That's probably not written that way, but it's a good sign. So yeah, again, the test is it's a provocative test, just try to see if you can reproduce, not the neck pain, but the arm pain from the nerve compression. And if they say, oh yeah, that's it, then that's usually pretty conclusive, if you can do it better than I can. So.
Can I ask a question about that?
Please, yeah.
In the picture and in the textbooks, they say rotate.
Yeah.
But in the photo and in my limited personal experience, it seems more like lateral flexion puts more pressure on it, and I have more luck. My sensitivity is 5%.
So it's interesting. So I've looked this up because it's like, why is my test so bad? Why can't I do this? I looked it up. It's described like 4 different ways.
Yeah.
And I think part of it depends on where what is your foraminal stenosis caused by a disc herniation? Is it caused by facet arthropathy? And so I think if you tilt your head different ways, you're going to cause more compression that way. But I literally have seen it written 3 different ways. Okay, so I actually. And I can't remember, because I actually found Sperling's original description, but I can't remember which of the ways it was because it was so confusing. Anyway.
Said it was 92% sensitive.
Yeah, that's not Sperling's exam. But anyway, so somebody's really, really good at that test. But if you send it to me and say it's a negative Sperling's and I find it's Sperling's, I won't be upset with you. So, anyway. Okay, so the equivalent for the lower extremity is the straight leg raise. Okay. Now, this shows, so this is actually kind of an interesting test because you have people that know that their leg is supposed to hurt when you lift it up. And they start, I don't want to say screaming, but they start getting upset the minute you lift their leg. That really doesn't take up much slack in your nerve unless you have a really, really big herniated disc. And the other thing that's important is this test is to test for a herniated disc. So if you think, I don't have any images unfortunately, but if you think about the patient who's got a herniated disc, they're lying like this, and their herniated disc is off here, and the nerve comes behind it, right? Okay, and they lift up their leg, all right? And that's going to cause tension on the nerve, and that would give you the pain down the leg, the reproducing the leg pain that you have, okay? But if you have spinal stenosis, they don't have a big herniated disc. They just have kind of circumferential compression, okay? So it's pretty common for the patient with spinal stenosis not to have a straight leg raise. And so don't find that surprising because, again, you're not tensioning the nerve against a herniated disc, okay? And, so that's part of the reason for that. So this again, so it doesn't usually, unless you have a very large disc, cause a lot of tension against the nerve, and then that middle range is where it's more common that you should cause a herniated, positive tension sign. Beyond a certain point, you're not taking up any more slack in the nerve, so it shouldn't make a difference for that. Now, this is, so the other way, another modification is the bowstring test. So you bend up their leg a little bit and then you press behind their knee to see if you can take up a little tension in the popliteal fossa, and that can reproduce the pain as well. Or you can dorsiflex the ankle, same sort of thing, just kind of putting more tension on that sciatic nerve. Okay, just different ways to provoke that. Now, this is useful for L4, 5, and S1, but the femoral nerve takes down L2 and L3. So for that, if you're worried about those levels, you have to actually do a femoral stretch test. Does anybody remember what that one is? Yes, exactly. So you lie them on their stomach and you bend their knee and this stretches their femoral nerve. Same sort of thing against the disc, okay? And then that's for proximal herniated discs, lumbar herniated discs. Okay. So these are again provocative tests. The other relevant finding is that if you have a positive crossed straight leg raise test. So if you have a herniated disc on the left side, it might give them a positive straight leg raise on that left side. But if you have a positive where you lift the right leg and it gives them the left-sided pain, it's almost pathognomonic for a herniated disc. Okay, so that's kind of a nice thing to have in your back pocket, like, wow, that hurt on the other side, whatever, and you're going to be right most of the time that that's a herniated disc. Okay. And then, let's see here. So before I go to the Waddell signs, I want to go through a couple of differentials. So for the upper extremity, okay, the things that we worry about causing things that patients complain about. One is, I don't know if you're going to talk about this later, it's carpal tunnel. Okay, so patients complain about numbness or tingling into their arm, and I have to figure out, is it from their neck or from their wrist, or their elbow for that matter, or cubital tunnel. Okay, so we always want to check a Tunnel's sign, you know, kind of tap the wrist for the carpal tunnel, and Brady can tell me if I'm doing this wrong. Or the cubital tunnel. And sometimes it's like, oh yeah, that's the numbness that I get. You know, pretty obvious answer. And the Phelan's test, you remember, is kind of dorsiflexing the wrist and kind of closing down the cubital tunnel. I had a patient today that we had to wait a whole minute, but then it's like, oh yeah, that's it. That I can tell it's spreading and whatever. And she's one of the classic ones with carpal tunnel who, at night, you know, her arm goes numb and her hand goes numb, and then she has to wake up and shake it out and things like that or whatever. So that's, you know, definitely one of the things in the differential that we worry about. The other thing I have to oftentimes clarify is shoulder pain. So a lot of patients have shoulder pain, and it might be rotator cuff, it might be impingement. And Seth is going to really laugh when anyway, so part of it is what they point to. You know, so shoulder pain, I had a patient today, he just pointed to his deltoid, it hurt, I poked there, it's like, oh yeah, that's it. Pretty obvious that that's the shoulder, not the neck, okay? But impingement syndrome, and Seth will have probably better diagrams of it. If you wanna, you'll basically be taking the rotator cuff and pushing it up against the acromion, which was this bone here, and you can aggravate that by bringing it across here or even twisting this way. And if that kind of gives the pain, then it's more likely to be impingement syndrome than from the neck. But there is a lot of overlap. You've got patients who it's the same age range. It's a little bit of wear and tear. They have patients that have both symptoms. And Seth will probably also go into rotator cuff injuries, because that's another common one that we have to differentiate. And that's a strength test, and he'll go into that or whatever. But again, so we're trying to sort out, and again, people can have both, and part of our job is to figure out, you know, I guess you have to figure out who to send it to. But that's part of our job too, and we send back patients all the time, and that's part of what we have to do to, you know, not just focus on our area, but to make sure that we are, you know, taking care of the right problem as opposed to a problem that's overlapping or a different problem. Yes?
So the rule, if the pain does not radiate past the elbow, it's your shoulder, it's not 100%. I mean, nothing's 100%, but I always thought that was the case.
That's probably true most of the time. Yeah, because I mean, the most common radicular level is C5-6, which would be down in here. Okay, so yeah, that would be most common. But we sometimes get C4, you know, and then we have to do the differential. And again, sometimes, I mean, I've had a lot of patients who've had both too, but that's a good guideline. Okay, other questions on that? Okay, and then for the lower extremity, two things we probably worry about the most is hip and sacroiliac joint. Okay, so the hip is relatively straightforward. They usually complain more about groin pain. Okay, and the patients I said this earlier, the patients they say their hip, and they mean this or this or this. You have to kind of see what they're pointing to. But if they point to the groin, you have to start worrying about their hip. And that can be hip arthritis, it can be a labral tear, it can be a lot of different things in the hip. And I usually use a hip range of motion to try to help me decide, like rolling the hip or internally flexing it and internally rotating it. And internal rotation is the one that most commonly elicits hip pain as opposed to, you know, any spine pain. Okay, and so if you find that, then you're more likely to have to refer the patient to a hip specialist, whether it be, you know, somebody like Saffron, who was here last year, who does hip arthroscopy, or one of the total joint people, depending on the degeneration of what the problem is. Okay. And the other one, which is a little bit vaguer, is the problem of sacroiliac pain. So the sacroiliac joint is kind of right where our sciatic nerves go, right? Okay, and it's probably the most poorly understood joint in orthopedics, and probably, you know, either underdiagnosed or overdiagnosed, depending on who you are. Okay, and I really kind of grapple with this, but probably the test that I do most commonly to look at number one is they have pain over that joint. Okay, and number two, you're nodding, do you know the test that I do for this?
Faber?
Exactly. What does Faber stand for?
So it's testing for, I guess, extending or flexing the joint?
Yep, F is for flex.
Okay, and then that's all I got, sorry.
That's okay, that's further than all your classmates here, so. Sorry, what, abduction? Exactly, so you flex the hip up, okay, and then you externally rotate it, and then you abduct it away, Okay, so it's kind of like a frog. I won't do that because I'm wearing a skirt. I can make Brady do it later. Anyway, but yeah, that's the test that I probably do most commonly. But you can also press on the pelvis, okay, and compress the pelvis, and that can reproduce the symptoms too. Okay, and the diagnostic test that we do if we think that is to actually do an injection to see if that helps the pain. But again, some people don't believe in injections. Some people have pain because the joint doesn't capture the injectate as well as some joints do. So some people feel like the injectate it's too diffuse. But that's kind of the current diagnostic test that we have. So
When you are compressing the joint,
I'm sorry?
when you're compressing the SI joint, are you having them lay on their side and then pushing?
That's another way
or
to
are
do
you
it. Yeah, I
putting them
usually-
on their back and kind of doing like pushing on them?
I do it when they're supine, but you can do it on the side. You know, if they really have SI joint pain, they tend to be in pain to get into that position. So I tend to do it supine. But I bet there are people who look for this joint more. I mean, like I think a lot of physical therapists are really good at SI joint pain. They're much better trained at that joint than we are. And I think they do a lot of side exams, and that's part of, you know, how they decide to treat it and manage it and stuff. But there is physical therapy directed specifically at the SI joint. And one of the reasons I actually believe in it is when I was at University of Minnesota for a year before I came here, and I would go do the women's sports, and I had a lot of patients that were actually seeing, you know, we were treating with all sorts of low back pain exercises and whatever, and a couple of therapists were like, well, I think it's their SI joint. They do this, you know, what do you think? Can we try some physical therapy if their SI joint? I'm like, sure, okay, you know, whatever. I'm a first year out in practice, I don't know anything. And so they tried it, and these patients all came back better. I'm like, oh, okay, I'm not sure what they're treating, but the way they're treating it is curing a lot of these people, these women athletes. So there's something in this that, again, I don't necessarily fully understand because I'm not well educated on it, but they can respond to physical therapy, so definitely something to keep in your back pocket. Okay, so the last slide that I have here is on Waddell signs, which are basically to help identify psychogenic or non-organic manifestations for pain. So these are basically things that the patient may complain about, but are not physiologic, okay? So if they have tenderness, like very superficial tenderness, you know that's not something deep in their spine or their shoulder. Well, maybe their shoulder, but not their hip, okay, or anything like that. So they shouldn't like jump off the table and smack you if you're kind of just touching their back, okay? And then if you press on their head, you think that puts a lot of pressure on their lower back? You'd be amazed how many people say, oh yeah, that hurts, okay? All right. And then, so distraction. So I mentioned a lot of patients say, well, they kind of somehow know that when you lift up their leg, it should hurt them. But when you're testing their quadriceps sitting, they're doing a 90-degree straight leg raise. And if they can do that, they don't have a positive. On the other hand, the patients that have true herniated discs, you do this and they're like this, you know, because it does hurt them. So it's kind of a way to kind of distract them from what you're doing. And then I mentioned earlier, if like their entire arm is numb or weak or something like that or whatever, that either is just because they have pain and they're having a hard time resisting strength, or they're magnifying their symptoms or something like that. So you got to kind of sort that out. And then sometimes you have patients that sit there and they're like, you know, moaning and groaning and owing and whatever. And so those exaggerated things, you got to wonder about the over-dramatization. And these are all kind of red flags from the standpoint, again, 3 out of 5 makes you wonder, is there really, you know, real orthopedic pathology going on, or is it just, you know, secondary gain or something like that? Yes?
What's your approach to these patients then, and also in the era of open documentation, how do you document these findings, or do you just keep the note from the patient?
No, I write exactly what they did. Pain is, patient has tenderness with superficial palpation. Patient has a negative straight legs raised sitting, but they were in agony when I did a supine. I just write exactly what it is. I don't try to put judgments, but anybody reading it is going to know what I mean. So, okay, any questions? Do people want to practice on each other or move on to the next one?
I have a question.
Please.
Just about the hip. I was watching a lecture the other day that with the hip, so they're complaining of like the anterior kind of groin pain, that with internal rotation, if it's positive for pain, that's more likely intra-articular
Yes.
to the hip, and if it's not painful with internal, extra-articular. Is that?
I'm not sure if I would know that it would be extra-articular, but intra-articular is definitely internal rotation. Okay, the extra, I mean, if you think about it, the Faber test that we're just talking about, if you keep externally rotating it and push it out, that's potentially an SI joint. problem, okay? So Saffron is probably better at the extra-articular hip problems or whatever. Oh, the other thing is bursitis. So don't forget lateral hip, you know, the trochanter or bursitis. And again, patients say, well, that's my hip, or that's my spine, or that's my sciatica, because they didn't read the anatomy book, they're just telling you what they feel. Okay, and then obviously they're very tender and they might respond very well to either therapy or to an injection there. Okay, great. So does everybody feel really comfortable with spine exams now? I can tell. Great. You have another question?
Oh, well, so if you were going to wrap up, and before you move on to the next person, in the spirit of sort of the value-based care context,
Yeah.
could you comment on when in primary care should we be ordering an MR, and when in primary care should we be referring?
Okay, no, that's good to bring it back to that. So if you just have pain, okay, and no weakness, and either a sensory deficit that is vague or intermittent, then almost all these patients deserve physical therapy first. Okay, if you have weakness, I'd be much more concerned about referring them or getting an imaging system. Okay, unless you have the red flags, as we mentioned. Okay, and then was that both of your questions? I think you had two questions.
Yeah, no, it's kind of the same thing.
Yeah.
When should we image and refer? I
Right.
think in primary care, if we find a potential sensory, deficit or pain and a dermatome, it's kind of exciting. Like
Yeah.
Oh, I think that's L+1, but it's not necessarily going to help the patient.
Right. Well, I mean, so many of them respond to physical therapy.
Yeah.
You know, and it is. I mean, in this day and age, it's interesting because obviously in the U.S. we have more MRIs than in like Northern California than Canada has in the entire country. So we're very good at ordering MRIs.
We use 8x the MRIs at Stanford that we do in the national benchmark rates.
Yeah.
Because our patients kind of expect it.
They kind of expect it. Yeah.
Academic
Yeah.
environment, and we
And
concern the anatomy. But
for better or worse, we're better at saying, oh, sure, because we're kind of curious, too. You know, you make this diagnosis, you're like, I want to know if I'm right, okay? And, but when you think about it, because, probably 80% of these people get better with just either tincture of time or good physical therapy, it doesn't change your management, for the most part. Okay, and a lot of physical therapists can kind of see where what makes their symptoms better or worse, and they can direct the physical therapy accordingly, as opposed to giving them the wrong physical therapy. Now, there is some physical therapy that's become much more cookie cutterist. I'm sure you've seen that, where everybody just gets everybody's back physical therapy is the same thing, and that can aggravate some people's symptoms. Okay, so I think that's the one piece that might be useful. But most therapists should be individualizing their treatment so that they're not aggravating the patient's symptoms because they're doing the opposite of what they're supposed to. But because most people do get better, I try to take the time and say, well, we're going to do the same regardless. I don't know if it's going to change anything. If it doesn't get better, then we can certainly do an MRI, because then we'd want to be thinking about what injection to get, or do you need surgery, or if there's something that we need to add to your treatment. But I think it is a mindset that we have to work to change, because part of it, I mean, I think we feed into it too, because we want to know, and it's easier if the scan is positive, it's like, oh, look at this is what you're supposed to be doing, or this is negative, I'll go away, whatever, you don't have anything.
I'm just curious what your response is to your patients in terms of chiropractor manipulation. And are there any specific situations where you just say, okay, you give that a try, or specific situations where you tell them not to?
So, unless they have like a neurologic deficit where I'll be thinking, do they need surgery sooner rather than later, I don't actually have an objection to chiropractic care, because people mostly, they do well. What I tell patients is that it should be something that isn't, there's some chiropractors that have you come 3 times a week for the rest of your life. That's a cash cow. That's not chiropractic medicine or whatever. So I tell them that your chiropractor should be treating you in a way that is time limited and should either help you or not help you. And that should be the way it is, opposed to this is, what you're going to do for the rest of your life. Physical therapists should give people programs that they should do on their own, as opposed to having to come to the physical therapist all the time. We as internal medicine people, you guys give them medication, they just need checkups once in a while. But the point is to make them better, not to make them dependent on you. And I'm supposed to do an operation or to give them therapy and make them better. And so that's kind of what I try to impart to them from the standpoint of where chiropractic medicine should be.
Question.
Please. I'm sorry.
Is this algorithm buried in the care set for spine? Because I know, like, I'll show a patient, like, once an MRI of their spine, and you try to put the MRI in. This is the tool I use, and it stops you. And there's a link in there. If you open that link, you can show the patient. Well, this is the care map that we use here at Stanford, based on research. And this is where you're not needing an MRI yet.
It is on the website. I don't think it's linked within Epic, but that might be an interest.
It would be
So,
helpful if it was
yeah, it
linked
might.
in the care
Yeah,
set.
right. It might be helpful, or to just have the care set on your desktop to show the patient if that they this is what we recommend, kind of thing. So, anyway, you know how hard it is to change.
You're raising the fact that patients put a lot of pressure on us. And
Yeah.
You know that it won't change management.
But if you show them that,
So having
they
an
feel a
expert
little more
and then, yeah,
comfortable
Right,
really makes a
saying,
difference.
this
That's
is
a
our
great
care
idea.
guideline, and this is
Yeah.
what we do at Stanford based on research.
Right.
And then I've had them back down. Okay, let's try that.
Yeah.
That's really good.
Yeah, no, it's good. But yeah, but unfortunately, you know how hard it is to change Epic too.
I know.
So in the meantime, having
It's embedded in the MRI where it is. but
Yeah.
like,
yeah, but
It's not, it doesn't look like this one perfectly, but it's in the link.
yeah, that's helpful. Okay, great, good point. Okay, well, thank you all very, very much. Appreciate it. And I don't have my email, but I think a lot of you already know how to do it. So thank you.
We're a little bit ahead, actually. So, if people want to take a break or keep going, I'm totally keep going. Okay, all right. That's usually the feeling. So, do you want to switch yours?
Yeah, let's try.
Is it okay from this standpoint if we switch the computer? Shouldn't change anything.
As long as you plug into the same cable.
Okay.
HDMI one?
It's got yours is.
Might need that adapter.
You take the adapter off, it just has to be the
Let's
same.
see if
Oh,
that's
they can. He can plug into the HDMI.
Yeah, cool.
Cool.
Yeah, you can do that. You can just HDMI, that's fine.
That's yours, right?
Yeah.
Okay.
This computer dies.
All right.
What could go wrong? Sorry about that.
No.
Not perfect yet, but
Looks good.
yeah, it's gonna be fine.
All right. So I'll go ahead and introduce Dr. Seth Sherman. He's an associate professor within the Department of Orthopedic Surgery. He's also the head team physician for Stanford football, as well as our orthopedic sports fellowship director. So he's very well known nationally and around the world for all sorts of sports-related things. So I'll turn it over to him and let him take it from there. Thanks for coming.
Hi, everybody. I'm excited to be here. It's 7 p.m. on a, Wednesday, so I'll try to keep this lively and definitely get us all out on time. I was late. I really wanted to learn from Serena how to do the damn Sperling's maneuver as well, but can't have everything. And I'll show you how we do it in sports medicine. But I was at football practice trying to keep the guys healthy for our first game this week. So my task tonight, first off, sorry I missed the intro, but can you, whomever, give me a sense of just who the audience is as far as all practicing or all internal medicine, just so I kind of tailor this. What's that? All family medicine? Oh. Great, all practicing in those three. Fantastic. Yeah. Yeah, cool. Excellent. Well, very good. Well, this is a really excellent audience for us orthopedists to talk to and really to help all of us take care of our musculoskeletal patients better. So that's the goal here. There's absolutely no silly questions, maybe some silly answers. But I'll focus mostly on knee and shoulder. So, my talk portion will go through really key aspects of history, physical, and imaging that inform our differential diagnoses for the most common conditions that you probably see and that we see. I'll at least get a volunteer, maybe someone with shorts for a knee exam and then whomever for a shoulder exam, just to see how we do our classic exam to tease this out, reproducibly, same way every time and within, 2 to 5 minutes in a busy practice, right? And then I think, as you alluded to with the spine, and Brady wanted us to hit on, really answering your questions about the timeliness and appropriateness of these ortho referrals and when to get MRIs and when we get them here versus when we should be getting them. And if you ask me on my Stanford football team, and if you ask my colleagues who work with the Niners, and we all work together, we get a lot of advanced imaging. So there's the board answers, and then there's, you know, daily life and practice. But it is what it is. You recording this? See, I told you got to keep it lively at 7. So just very briefly, background. I'm from Staten Island, New York. Has anyone been there? Serena's been there. Excellent. So it has home of the largest garbage dump in the continental United States, and the Wu-Tang Clan, which I loved growing up, and my dad was an orthopod and took care of a lot of these guys. So that was an interesting upbringing. I loved the Knicks, and that's as far as I got. So that's my sports upbringing, JCC basketball. I stayed on the East Coast. From New York, as I said. I went to UPenn and then Cornell. Stayed in the city at HSS, where we have common roots and background, and then left. I learned, my future wife taught me that there's life outside of New York, so that was interesting, and went to Chicago for the year, worked with the Bulls and the White Sox, landed at University of Missouri for 8 years. Before mentor and friend, likely many of you know, Mark Safran, recruited me back here. I was his, I think, undergrad or med student at UCSF 20-something years ago, and we would eat Chinese food in the middle of his busy clinics and driving his convertible, and I made him a mixtape in the OR back then, and so something clicked because we stayed, you know, in communication, and he brought me back here about 3 and change years ago. That's my wife and daughter. Now we have a COVID accident, 1-year-old son, Hudson, who I have to add to this. But that's my grandfather. So he was a team doc in Brooklyn about 50 years ago. They named a field after him while he was alive. He treated patients for free from all the high schools. He had Doc's Clinic, and I was able to see that on the sideline with my bowl haircut, and actually learned from my dad, who's a community doc, the Lockman exam and sideline assessment, you know, in those high school athletes. So it was a special time. This is me not being a team doc, but being a spectator on the sidelines at Missouri when we lost to Georgia at the end of the game, and then our only glory last year was against Oregon when we beat them on national TV, and then the rest is history. But I was the only one adhering to guidelines and wearing a mask, so there you go. This is just, I'll give you guys all this information. My website has a bunch of information, actually links to a lot of our typical sports medicine sites and a lot of animations, just so that you and your patients can get more information. I tried to make it a central repository or hub for things. The things that I focus on the most are, you know, knee injuries. So in the knee, I don't just do bread and butter. I do kind of failed sports medicine, if you can conceptualize what that means. So 20 to 50-year-olds who are not ready for full replacement. They've had 2 to 5 surgeries. They can't play with their kids. They can't do their job. They're in dire straits. They may need bigger things like realignment surgery, like replacing cartilage, like putting in meniscus transplants, not our routine ACLs and meniscus surgeries. So that's kind of a sub-practice of mine, including complex kneecap conditions that even our partners kind of don't want to deal with and send my way. We all do at the highest level many of the things on that list I just showed, and hopefully do it as well as anywhere. We also take care of shoulder conditions, so that's really soup to nuts from the younger athletes all the way up to the total and reverse replacement. So our group has comprehensive care for the shoulder. Sports medicine is kind of a grab bag, as you all know. As far as biologic injections, our non-operative partners team up with us to do those, but we're often the ones who are steering the ship, or at least conceptually referring them over. And then there's a lot of things in sports medicine that are strains and, you know, minor contusions, and what needs a workup and imaging, and then what's going to get better with the tincture of time and maybe some rehabilitation. So it's kind of a lot. Like most of you, we're here because we wear multiple hats in leadership, and education and research. And I think the biggest thing that sports docs do, or I hope to think we do well, is communicate and collaborate. We are always wanting to kind of be texted and bothered. Like we're constantly communicating with our trainers, often with our athletes, with our collaborating docs. So, I think that kind of relationship is super important, and it's just the easiest way to get hold of us. I know sometimes Stanford can be like Fort Knox, but that's why, these kind of sessions can, kind of build those bridges together so that we can get these patients in a timely fashion when they need it. So hopefully that was kind of the quick and dirty about my practice and my interests and passions. Now we're going to kind of focus on what you likely need or want to know and why you're here. Ortho exam can be and should be simplified. It really, I used to not like when my mentors, I hope they were seemingly older and grayer than I am to the residents and fellows, but when they would say that you can learn 90% of this from the history. But it's so ridiculously true in our field. If I know the patient's age and I know a few minor things about mechanism of injury, was it an actual injury? Did they get hit by a bus or get run over on the field? Or is it insidious, right? So insidious or traumatic, then really my differential diagnosis can be pretty focused already before I even walk in the room. And so, we kind of, to some extent, go out of order, and you may do the same in your field for efficiencies, armed just with that history information and maybe their most basic x-ray presentation, whether they have no arthritis, no fractures, or full-blown arthritis, or somewhere in between. I already have a mental picture in my mind of the 2 to 3 things that I need to tease out with my physical exam, which really, for our field, is a lot more where we can actually touch almost all of the structures that might be injured. And we really are just testing hypotheses, right? So I can fairly easily differentiate, let's say, a rotator cuff tear from a frozen shoulder. They may both have pain, and we'll go into some examples of that, but it's extremely powerful if you just keep it simple. What age range are they in? The young shoulders will have instability, they'll be dislocating. The older shoulders really won't dislocate unless they had a huge injury. They're more rotator cuff, more impingement, or more overlap conditions. And there's so many other that we'll allude to with knee as well. And then imaging for us is confirmatory. All right, so there are some examples where it helps us to hone in on that initial diagnosis, and I'll show you that. But really, the imaging, particularly the advanced imaging, is not because I'm fishing for a diagnosis. It's because I know with an extent of certainty what it is, and I'm looking to confirm that and then plan my non-surgical or surgical approach. And so, we see a lot of times, obviously, where if we don't have confidence in our history and our physical, then we're obviously going to have to lean into the farthest bucket, and that's where we image or over-image. And imaging shows a lot of things, and a lot of things that are not relevant. And our patients get extremely scared about those things. Causes anxiety. It causes inefficiencies in our kind of practices to unexplain findings or show number 3 through 6 on the radiology report and why they may or may not be relevant. So, I think just going through it systematically can kind of help us. So I'll show you some examples here in this segment, more case-based, just because I knew it was going to be later, and hopefully you'll get similar meaning out of this. But I do want to show you and walk through soup to nuts the exam as well, so you understand each of the maneuvers and what they're testing for. So we'll do both. But here's a kid. He's a 17-year-old football player. He had an acute injury, so it's a trauma. It's not contact. It's a twisting injury. He felt a pop. He was unable to play, right? So we have a picture in our head. This one, we kind of have things screaming in our head about what might be going on. When we examine him, he has big swelling. Anytime a joint is effused, there's a problem, right? If it's a trauma with an effusion, that's either joint fluid or blood. If it's not traumatic and they have a fever, that could be pus, right? So we start thinking about things when we have joints that are big and swollen. So really differentiating in our patients a dry knee, that's likely a more happy knee, and a less urgent knee from one that has an effusion is really a big task, and I think we can all kind of master that, and I'll show you how. And frankly, in this kid, the rest of his exam is difficult, and so you can't really tease out all the classic tests. You want to test for his ACL, his PCL, so we kind of have to get a sense of what's going on. We do get imaging routinely. I think just to throw it out there for our clinical day-to-day, we get x-rays on everybody in orthopedics. It's our first line imaging study, period. So that's every patient that walks through my door gets x-rays of their joint. Their knee in a walk-in type clinic, not in our football stadium, will get weight bearing, AP, PA flexion, lateral. They'll get some sort of an axial view of the kneecap joint. And because of my subspecialty practice, I also do that long leg alignment view, the mechanical axis view, but that's not typical. And you guys don't need to do all of those, but I think you need to do some of those if you can. And if you're thinking about things that might be changed by a weight-bearing view or not, you should get the weight-bearing view if they can walk, right? If they can't walk, or if it's a acute trauma and you're just ruling out a fracture, of course it's fine to get a non-weight-bearing AP and lateral as a screening test. But if we're trying to stick to repetition and principles, I think that's my standard series. I'm always trying to go back to that if I can. Yep.
If we've decided for other reasons we're sending to ortho, should we order the x-rays, or does that just get in the way?
Yeah, I think, in most cases, and hopefully after this talk, I would think that you would have some at least precursory imaging to funnel your differential diagnosis to gatekeep to see if they need ortho referrals. But if, for example, this kid came in to you guys first, he had a lot of swelling because it's 2 or 3 days later or more. You get the basic x-rays if you didn't get him in the ER to make sure there's no broken bones. Then I don't think it's not practical that you're going to get my standard weight-bearing series. So I think referring that one, and it's a reasonable time for an acute traumatic injury in a young person with swelling, an MRI is more than reasonable. So, I mean, that one is one where we do benefit from early imaging, which is different from an older patient with chronic pain without a large effusion that's had no conservative treatments. That one would benefit from our history, our physical, reassurances, x-rays that probably show moderate arthritis, and maybe all the conservative pathways first, right? But I think we have x-ray in our clinic, so it's not critical that you're getting the views. It's always hard because we often do wind up getting repeat imaging or additional imaging that probably costs these patients. So obviously standardizing to some extent these pathways so that we don't have to get all of the imaging again makes sense. But in an acute setting, you have to do what you have to do. I would expect non-weight bearing or limited views from the ER urgent care or even from your clinics, but an awareness that it's a real injury in a young person and moving the ball along to get to us, and maybe even ordering that MRI. So hopefully that kind of helps you with that type of patient. We'll never frown upon that one because that's the appropriate care pathway. This x-ray over there is normal, just to differentiate the same kind of history, trauma, young person. This x-ray, what's going on here? Anybody know? Yeah, so patella tendon's ruptured, right? The kneecap's in outer space. So just by differential diagnosis, a little rare, but this can have the exact same presentation as that ACL, right? The classic ACL or patella tendon rupture. These are ways to have our differential diagnosis. Probably this one couldn't straight leg raise. They'd have an extensor lag, and then you get this imaging. It's clearly confirmatory. Similar type thing, the normal x-rays that our ACL kid will have. What's going on in this one? Yes, I mean, this one's fractured, right? Both will have swelling. Both may have hemarthroses, right? Blood in the joint from fracture or from ACL rupture, but clearly that's a spot diagnosis. Again, if you stick to the ABCs, the principles, history, physical, and some, cursory imaging, you're not going to miss that. So, that's helpful, and it's totally different, right? Different care pathway. That might be a CT and referral to our trauma friends, right? And not a MRI only and a referral to sports medicine, right? And that likely should be potentially considered if they're going to fix it, in a timely fashion, within a week or two. So, that stuff matters. Picking this up on x-rays by getting the x-rays, matters. And knowing that it's in the differential diagnosis of these young traumatic injuries. But, the things that are mostly in our wheelhouse are going to be the ACLs, right? It's always, you hear pop a young kid, that's what it is. But it could be patella dislocations. It could be a different ligament. It could be meniscus pathology. But really, the awareness of the care package is more important than the specific diagnosis in your guys' hands. Knowing the acuity and knowing, how and when to get it into, our hands. And then, really it comes down to teasing this out or confirming it, right? So a lot of these patients will have that white in the joint, the effusion. You can see on that axial view. Here you can see the bone bruise pattern, right? The back of the tibia, the mid-femur, because it's a big rotational injury with an ACL. So that's our classic bone bruise pattern. You can see here on the right, that's a normal PCL. We can go right next to it, and you can see that ACL is ruptured, right? So whenever you see that bone bruise, and then you look to the slice in the notch, you're not going to see your ACL. So that ACL is gone. Here you can see a normal lateral meniscus. We know it's lateral, obviously, because of the fibula, all right? And we can look at the same kind of view and see there's signal in the meniscus consistent with a tear, right? And so these are some of the nuances that we'll get out of our MRIs, confirmatory tests for ligaments, understanding if there's concomitant meniscus pathology or other injuries that'll help us to treat these patients. Does anyone see an abnormality on that right MRI? So that's an interesting one called a double PCL sign. The one on the left's normal. There's only one PCL. The one on the right is a double PCL because that medial meniscus is in the wrong spot. It's actually flipped like a bucket handle and in the knee. And so another important thing that goes along not just with effusions, but if you really are suspecting in a young athlete that there's a locked knee, and it can be hard, but a knee that really has firm endpoint, can't extend, that's potentially a bucket handle tear that's locked in the joint. That's potentially an intra-articular loose body, a marble in the knee that's embedded somewhere it shouldn't be. Sometimes we can be fooled, and those chronic arthritic patients without the big effusions with a drier knee, they can have bone spurs and osteophytes and have lost motion and flexion contractures. So these are not hard and fast rules. They, again, have to be taken in context, the right patients for the right problem. But nonetheless, if you suspect a locked knee, you should get advanced imaging study to confirm that. And I think any traumatic injury with a locked knee, is a very clear-cut kind of referral our way. Here you can see, looking from the front, you can see the triangle-shaped lateral meniscus. That medial meniscus is gone because it's in the middle of the knee, right? So on the coronal, it's absent. On the sagittal, it looks like two PCLs. That's pretty classic. So that's a locked bucket handle tear. Here's what it looks like in the OR. So basically, that's the meniscus in our face, and we basically push it back where it belongs with that probe, and then we fix it. We are really trying these days not to trim meniscus. We want to preserve the shock absorber at all costs. And so I think a paradigm shift here across the country and the world is really trying to save and preserve meniscus if we can. And we can't always, but we try, and we think about it every time. So repair strategy, not meniscectomy. So here's kind of the same patient, but a little different. Your exam can be hard. You may not get a perfect Lockman exam or a pivot shift exam or even a kneecap examination, but there was a trauma, there's an effusion. And then in this one, you can see a different bone bruise pattern. You can see on the medial side of the patella and the lateral side of the trochlea. And this is a classic patella dislocation. So same patient, little different physical exam and a different MRI. And a whole different set of problems, right? You can see here, this poor kid knocked off a big piece of cartilage, which is a surgical indication after dislocation, right? A loose body or an osteochondral fracture after a kneecap dislocation should be removed or hopefully fixed. And at the same time, we should stabilize that joint so it doesn't happen again. So that's an indication where we do want, again, that prompt treatment, recognition, and referral. right? So that's important, and that's kind of what that looks like. This is just showing how we do soft tissue MPFL surgery, stabilization. So not the ACL reconstructions, but that's for patella. We do MPFL, medial patellofemoral ligament reconstructions for those patients. Here, same kind of story. The one on the left looks pretty good. The one on the right looks like a bomb went off, right? So the collateral ligament here looks normal, black, looks like a disaster here. Similarly, on the lateral side, looks nice and normal. It's a disaster. When you start thinking about more than one ligament injury and a high velocity, our guard should go up even more, right? These are multi-ligament knee injuries. These can come in sometimes even to your clinics looking fairly benign. They could have fully popped out and popped back. They may come in a couple of days later. We have to think first about neurovascular, right? So anytime you suspect major multiple ligament issue or injury, we think about pulses, we think about getting our Doppler out, we think about side-to-side symmetries, we think about your sensory and motor exams of the distal extremities, we think about the calves and compartment syndromes. It's just a different, and these always come into my clinic on Friday afternoons. And that's why I'm really like close with Vanita Chandra and vascular. I have her text, so I text on a Friday afternoon as I'm getting the dreaded Doppler out and making sure this kid's not going to lose his limb, right? Because, and you can tell this by the history. These are pretty violent injuries, but they can be sporting injuries. You can tell this by physical exam. They may not have huge swelling like our ACLs because everything's ripped, right? So it may just be diffuse and running up and down the leg. So you can't just go by swelling in these. However, with even a simple examination with the leg straight, you should never, and you can try this on yourself, be able to push someone varus and valgus and have any play whatsoever in any scenario. None of us. We all, when our leg is straight, have no play, which is very different than when we're in any degree of flexion, particularly 30 degrees, where we're testing specifically the MCL with valgus stress and the LCL with varus stress. But at 0 degrees, if you have any gapping open, and these kids, they're in pain, they're nervous, you're nervous, right? It's a big injury potentially. You can very simply, and I'll show you, just try to maneuver their foot and see if they gap open at all. I mean, that's a potential multi-lig, because you can't get that without rupturing the collateral and even the ACL with it. And so when you start thinking about 2 or more ligaments, you're really not going to be able to do that many more tests in them initially. Good luck trying to get them to flex up to 90. There's not going to happen right away. So our index of suspicion has to trigger that with tenderness, swelling, and then with that simple, just making sure they don't gap in extension. So that's one pearl that'll send you right to your, red flags, your neurovascular assessment. All right. If incidentally any of those patients, you find any palpable deficits in their pulses distally, you can get the Doppler out. We can send them here for ABIs, right, or send them to urgent care or the ER. They can do CT angiograms and get to the bottom of it before the weekend, right? You don't want to sit on those types of things if they wind up in your office, and they will, and they do, and they wind up in the late afternoon. Right, so that's when they come. Here's another spot diagnosis. So this kid is 12, right? So, and he had no acute injury, so just kind of chronic, smoldering pain. His pain, when you ask, I always ask, point with one finger where your pain is, right? So his pain's right there. My field's not rocket science. It just says a lot to put together. But one finger pain in our field is critical. I ask every patient every time. Use one finger, point. Guess what? If they can't do that and they do that, that's another diagnosis, right? They have diffuse, non-localizable pain without swelling, without trauma. It's in the front of the knee. Their ligaments are stable. That's the bane of all of our life and existence, right? Anterior kneecap or patellofemoral pain. Now, I love the patellofemoral joint, so I have to see a lot of those patients to get to the ones that dislocate or the ones that actually have focal cartilage defects or profound malalignment or combinations or fail all the conservative treatments for patellofemoral pain and may need some of the things that I do. So that's why I partner with a lot of great non-surgeons who take interest in the patellofemoral joint as I do and love teasing out why they have pain, what's it coming from, how we can make it better without our hands, and so you really have to dive into love things like that. But, I think that's a very different patient who's like this without swelling than this kid who's now 12. And 12-year-olds without trauma, raise your hand if you've seen a medial meniscus tear in a 12-year-old that didn't have trauma. I've never seen it. Raise your hand if you've seen a 45-year-old with a medial meniscus tear without trauma. Yeah, I mean, that's like half our practice, right? If you get an MRI on me, I have a medial meniscus tear. I'm varus. I have intermittent pain here. What else is going on, I haven't taken x-rays. I don't know how much arthritis I have. But, that's the classic patient. But in this 12-year-old, again, history, right? So age and then mechanism of injury, which for him is none. Just insidious swelling. And then physical exam might show trace effusion, some tenderness on the medial side. So it gets your brain going. And then your standard x-ray series gives you kind of the diagnosis. Do you guys know what this diagnosis is? Yeah, I think that's probably more relating to the way the x-ray is taken, because he, on a PA flexion view, has perfect space. But that's not arthritis. But you can see inside the bone on the condyle, see how that kind of area has like some cystic changes, irregularities. If you look at the lateral side, that bone is perfect. And then you look at the medial side, that's more hollow. There's a little more black in that bone. And that's a pretty typical or classic look for an osteochondritis dissecans defect or an OCD, right? So these kids are more prone to things like that. Atraumatic, insidious. If you get an MRI, you can see here that there's abnormalities both within the bone and the cartilage cap, all right? And for this particular one, we see fluid behind it, which indicates to us and the radiologist that it's not a stable OCD, right? Some of the stable OCDs, or most of them in these young kids, can be treated without surgery. But these types of unstable OCDs, this is what they look like when you're in this operating room. That's a crater. So like a manhole cover, right? So that's how the fluid gets in behind the bone and cartilage. And so we literally want to preserve this 12-year-old's joint. We treat this like a fracture. We actually clean up the bone behind it. We put the manhole cover back, and then we put screw fixation in it, and then we do rehab and hope that they heal and save their entire joint from having to do other bigger or different things. And so that kind of recognition and awareness just of the age, the mechanism, your physical exam findings that are reassuring, because this kid's ligaments are perfect, and then that narrows your differential. Having the wherewithal to get your standard imaging and then get advanced imaging because your suspicion's high can lead you to the right kind of diagnosis. And he wound up doing really well and healing it. So we'll switch kind of to a couple of things in shoulder. So here's a typical young athlete, acute pain, well, kind of up and out, trying to block a shot. You can see the deformity there. They can have a dead arm that's now resolved. Very difficult kind of examination at time zero. I think in the shoulder, the classic things that we do besides our history, our initial physical, we try to get our routine x-rays every time. So for us, that's that true AP or that Gracie view. It's that scapular Y view, which is from the side. So that's our lateral. And then the one that orthopods always harp on is the axillary view. This is an axillary view. You can see that this ball is lined up with that socket. Nobody can argue that that ball is lined up with that socket. If you just get an AP and an internal and an external and a scapular Y view, and you treat a lot of young shoulders with acute injuries, you're going to miss a dislocation. Period. That's why we get it every time. That's why we harp on our residents. That's why we call the ER. That's why we add that as the additional test when they come from other clinics to our clinic, because we don't want to be the ones missing locked posterior dislocation that could be chronic. I've seen it. Or a fixed anterior dislocation that we need to do something about more acutely. If you stick to principles and get the right images, you're not going to miss those things. So, this is what it might look like, a true dislocation. There's the axillary view, so you can see the ball is very far anterior. You can start to understand how you can get divots in the back of the head, the Hill-Sachs defect. You can understand if this happened 2 to 200 times, how you can start wearing down that socket in the front, right, that golf tee. And getting some bone loss and making a simple situation hard. You can understand in this person who is likely electrocuted, classic, that the dislocation's posterior, right? So seizures, electrocutions, they can come in. They may have other comorbidities. It may be distracting. It may not have happened this week or last week. Could have happened 3-4 weeks ago. They have limited shoulder range of motion, pain, hard exam. You get your typical views, you're going to see this locked posterior dislocation. You're not going to miss that. You're going to be an all-star referring that to your colleagues who need to do an open surgical reduction on that. All right? So don't miss that. Incidentally, you can see the coracoid process. That's your lighthouse to anterior, right? So you know that that's not an anterior dislocation because the coracoid's anterior. So in a case likely similar to what Serena was describing, where all of the shoulder x-rays look perfect. They have no obvious apprehension when you bring their shoulder out to the side. Maybe, you have to think about other things in a acute traumatic injury. Maybe it's a traction type injury, and that's where a comprehensive, any shoulder examination that I do starts with the neck, but it really starts with the history. It's very typical, the one finger pain thing, if they're diffuse and they're here or in the shoulder blade, or if they say it's radiating down past the elbow, as we alluded to before, that's very different than pain in the shoulder, here, here, here. That's my wheelhouse. My wheelhouse is not the armpit. My wheelhouse is not the shoulder blade, not there, not pain with neck range of motion, not pain with spurling, not pain that goes past the elbow, not 10 out of 10 pain. Very few of our things, besides fracture, in sports medicine have 10 out of 10 pain, that out of proportion pain. When I come in the room with the shoulder, I didn't say it before, but when I come in the room with the shoulder patients and the lights are off, or they have huge thick glasses, or they're sitting in the corner, kind of the shell, that's a spine patient. I mean, it's like, I don't know what that sign's called. You can describe it in your note descriptively, but that's not a patient that needs my attention for shoulder pathology. And then you tease out why, right? And the why is because of all the Waddell signs or Waddell signs, and because when you look at their shoulder exam, you have to be confident you can get full range of motion, you can test their cuff strength, you can make sure they have good stability. You don't want to be distracted and miss something. That would be embarrassing, right? So it's a diagnosis of exclusion first, but you know where you're heading in the majority of those cases. And then as long as their images look clean, you can confidently discharge them from our clinics and send them to the more appropriate places, or they wouldn't make it to a shoulder clinic in the first place, right? And so that's kind of the point, to get the right patients to the right ones of us who need the right things at the right time. So here's a couple other spot diagnoses, same kind of acute trauma. What's this one? Yes, I mean, that's a clavicle fracture. Could be the same presentation, just a little different history, physical, and another, but same type of x-ray. You got a totally different diagnosis and treatment course. What's this one? Yeah, so this one, you can have that same type of incident or a direct blow. Fall off a bike's a big one on Stanford campus. You may see prominence at the AC joint. You can ballot it or palpate that, and then you get this x-ray, and then you've confirmed your diagnosis, right? Just going through, anytime we pull on or push on anything, we get x-rays after. So I think that's just good principles if you're doing any of that in your practices or if you cover any teams. We always think about the golf ball and the golf tee. It's just a useful analogy for patients. Or you can think for stability of the capsule and labrum being like a hammock. that stabilize you so you don't fall out the front or the back. Either one or both can be helpful for our patients. These are kind of the classic things we see in the young. So this Bankart lesion. So this is the front of the shoulder. That triangle is the anterior labrum. You can see the anterior labrum and the capsule in a dislocation are ripped off of the socket, right? So that's what happens when the ball goes out the front. This is what it looks like. We're looking from top down. So we're looking at that labrum, which is this thing here, which is ripped off of the socket, which is this thing here. So that's what we fix in these shoulder dislocations. In the shoulder, many of these dislocations in young people are kind of one and done. We want to appropriately see them, get x-rays, likely get advanced imaging and send them on quickly, because we know from natural history studies that the relative risk of them popping out again as young high-demand athletes is really, really high, and that if they do that, they might damage that further or damage the bone or make something that might be straightforward and reproducible surgery harder with a worse prognosis. And so that decision should be made by a surgeon. So dislocations, in my opinion, should be referred. Those posterior shoulder problems, those are more when they have issues cross-arm, when they load the back of the socket. So anteriors are more up and out, right? Mechanism of injury. My football linemen, when they're pushing like this, or people fall on the floor, they're going to push the ball out the back, and they're going to injure the posterior labrum. Posterior labrums, they don't always, except for those electrocution or seizures, pop out the back. It's not like an instability problem that's like a big event. If you dislocate out the front, everyone knows about it. We got to pull on it. You dislocate out the back, you may pop in spontaneously. You'll have pain. You may not even say you have instability, and so it's just more just awareness of who those patients are, which position they have problems in, and you can load that arm and really tease that out for them. And then the other part of the labrum that we see in these patients, so our throwing athletes have issues with the top labrum and the biceps, right? So that's the slap tears or slap lesions. But people who have like a fall from a tree, like a traction injury or things like that, pain in the front and back, and pain when you load the biceps, it's pulling on that superior labrum. That clues you in to more of that superior labrum. And I think for you guys, just really having a sense that these things exist, knowing from the history a suspicion of possible labral front back, top, and knowing the relative acuities, which ones you might want to get imaging and refer sooner than others, I think is really the game, not just the nuances of is it, a slap versus a posterior superior, or is it 360 versus 270? That's for us, right? Or how much bone loss, that's all for us. But having an awareness of these things, I think will help you to kind of triage them. I want to spend some time on the older shoulder because that's probably what a lot of you see a lot of the time. And I think this is probably, when I made this talk, kind of the best example of kind of that ABCs, like the history, physical, imaging, and pulling it all together. Because there's minor and potentially subtle variations in the presentation and our exam that changes everything, as I'll kind of show you. So this is a 65-year-old female, 6 months of insidious upper extremity pain, so no trauma. So, here we'll kind of go through a couple of different iterations of it, right? So for the first patient with this history, their shoulder exam's perfect, right? They have great range of motion, great strength, but they may have a positive, whatever you call, spurling. They may have, complaints of radiating pain. They may have some other signs that really push you, towards the neck. And when we get shoulder imaging in a shoulder clinic, it looks perfect. And if you either refer or order the shoulder, they may have some arthritis, right? So shoulders clean and their exams clean. Their history points right to the neck, and then their basic C-spine films have bone spurs, and they have limited range of motion. When you load them, they have some pain or maybe some shoulder blade pain. I mean, that's a care pathway, right? That goes PM&R or to Serena and team in that kind of way, depending on severity. What if we have the same patient and their neck exam's totally normal, which we check first, but their shoulder is both painful and it's weak, right? That kind of patient, they have normal appearing x-rays, let's say. So the AP looks normal. On the scap Y, you can see they have a pretty significant acromial kind of spur. Chronic, nonetheless, but that kind of clues you more into the possibility maybe this is a shoulder problem. They have pain in that location, not radiating, and the neck's perfect. And those are the patients with frank weakness when you test them that likely have the rotator cuff tears, right? So that's a very common one. And I guess just to try to answer the questions of when we get MRIs for some of these as we go, I think if you have chronic, insidious pain and weakness in a relatively low demand or elderly patient, you think they have a rotator cuff tear, probably can sit on that one and do some things first and see if you can compensate. If you have a 40-year-old laborer who had a trauma and has rotator cuff weakness, I'm going to get an MRI every time because we might fix that acutely, right? Whereas if this person's had this for a long haul, you can tell them they likely have a rotator cuff tear. I wouldn't sit on them for 6 months to 2 years, but if they're getting better with NSAIDs and with maybe, there's debate about injections for true cuff tears these days. We can talk about that, but I think it's worth a bit of PT and time in those chronic insidious cases where it's really not worth it in those acute cuffs. And we're talking specifically for patients with weakness relating to the rotator cuff. So traumatic, younger, weakness, MRI and refer. Older, insidious, weakness, can try some conservative things before an MRI and referral. If we have a patient like this, where their neck exam is normal, their shoulder is painful but also stiff, right? So on our rotator cuff person exam, I can move their arm with the arm at the side all the way in and all the way out. All right? There's absolutely no problems with passive motion, and I can lift their arm all the way to the ceiling. But when they do it, they have weakness or pseudo-paralysis, and when I push down, they're weak, right? But I can get them there. They're not stuck. If that same patient presentation is painful, stiff, and stuck, they can't do it and I can't do it, what's that diagnosis? Yeah, and so, these are pretty straightforward ways with your mind and your hand with one exam maneuver, and so many times the residents and fellows miss this. They're thinking cuff, impingement, other things, but they don't realize the subtlety of just being locked in adduction, not being able to externally rotate in the right patient, right? That's frozen shoulder. And so that's obviously not something we would rush to an MRI for. It's obviously not something we're going to rush to surgery for. That's clearly in our non-operative pathways. Rarely they do come to surgery and we have to do things like you see here, like cutting that capsule. So we release the white so we can see the muscles. We manipulate the arm to get motion back. Totally the exception and not the rule, right? Treat their diabetes, treat their, get them into therapy, and most of them thaw out over time. So that's clearly not one you have to rush for. Here's similar patient, right? Neck's normal, shoulders painful and stiff. But that's their x-ray. So what's this one? Is this a frozen shoulder? Yeah, that's arthritis shoulder, right? So same exam as a frozen shoulder, but a totally different diagnosis and care pathway, right? So just the power of these images. This cuff is intact. This is a patient, and our hands would get a total shoulder replacement if they failed conservative treatment. Again, there's no urgency on that referral. This is acute. This is chronic, insidious. You have great confidence in what's going on. We won't touch these people and do big open surgery unless you all did your thing, with PT, medications, potentially injections, and time, right? So those are kind of the ones that can be teed up to have surgery later on because they've checked all the boxes. But if they're doing better, they can just be your happy patients who are out in the world with arthritis like everybody else. We don't need to see them. Yeah.
How often do you utilize bedside ultrasound instead of MRI for example, a rotator cuff tear that you're suspecting in terms of saving costs for the patient?
Yeah, it's a good question. Our short answer in orthopedic surgery sports medicine is never. In our PM&R or non-operative family practice internal medicine, people who are facile with ultrasound, or you guys, if you are facile with it, I think that'll just empower your initial examination, right? Because it would be great to know if that's a big cuff tear on your ultrasound exam or no cuff tear or a partial tear, the grab bag of everything else, right? Everything else doesn't matter. You want to differentiate big tear. So if you had that 40-year-old traumatic guy and you're confident, he had weakness, he's in pain, but you look at the ultrasound and that cuff's probably mostly intact. I mean, there's definitely many fibers going from A to B. Yeah, you can see him back in observation and not have to urgently rush on that one. Whereas if you had the same guy and there was nothing there, I would get the MRI and refer that one. Similarly, we use, if we have MRIs, and invariably we do on these impingers, right? So they're kind of the middle ground population that has maybe no cuff tear, but they have pain, but they're not stuck or frozen. They don't have significant weakness, maybe some slight weakness. That's the majority of our patients. The impingers or the partial cuffs, those are very much in our non-surgical bucket. You can put them there with the AC joint arthritises, with the biceps tendinitises. Those patients are not op till they're not. Those can have reasonable understanding of where their pathology is from your history and your physical. Look at their x-rays so you can confirm some things are reassuring. You can do rehab and meds and injections and time, and then get MRIs when they're ready for surgery. And most of them will do great and won't need to see us, frankly. So I think that's a good example of that. Here's another one. This is cuff tear arthropathy, right? So a little different take on it, where you see they have a massive cuff tear that's chronic. Their humeral head is riding up, hitting on the acromion. These patients often have pseudoparalysis. They're often 70, and they do great with reverse total shoulder replacements. Again, if this is chronic insidious and you see these things, don't panic. You can do non-operative treatments, but if they fail it, they have good surgical options that are really excellent for that elderly population. Here's just one spot diagnosis for the shoulder. The 45-year-old who has kind of sudden onset of shoulder pain that's like extreme, like can't move their arm, like agony, no reason for it. Maybe they just woke up that way and boom. Anybody know what this diagnosis is? Yeah, so this is calcific tendinitis. What would be the other thing on your differential that's really, you don't want to miss in someone who out of nowhere just had sudden but atraumatic but severe pain and inability even to move the joint even a little bit? What's like the other thing we want to think about or rule out? Any joint where you have sudden severe pain and really difficulty even to range it at all. Yeah, we're thinking about infection, right? So it's a great mimicker, but again, that's in the back of our mind. Your temperature will be reassuring, as will your other vitals. The exam may be challenging, but then you get some confidence from seeing that calcium deposit that it's likely calcific tendinitis. It's the right age range for it. It's the right clinical look of it. Basically, that calcium sitting in and around the rotator cuff, inert, and then it can essentially resorb or melt and cause tremendous pressure. And that is one of the most acutely painful things. And we can make like best friends in our clinics by doing injections for these people. I mean, these are some of my happiest patients, non-op. And, as a surgeon, our best patients, don't not send all the non-ops, because when we get people better without our hands, it's exponentially better for us, everybody. They tell 100 or 1,000 people. Whereas if you do well with one surgery, they tell a couple of people and you get some referrals. So we're always like loving diagnoses like frozen shoulders and calcific tendinitis that we know are non-surgical and that truly have a natural history that's favorable. If they're sent to us, we'll treat them and get them better, and that's rewarding as well. So, I guess that's kind of the key points that I wanted to get through. Maybe just for now, maybe Brady, you want to come up and I'll do at least the neck and the shoulder exam the way that I do it on him. I would like someone can get Curry who has shorts. Maybe we'll jump up on one of the tables for 2 minutes just to show the knee exam, just so you see how I do this and what tests I'm doing. And yeah, we'll do that in a couple of minutes. You can build your courage up at 8 p.m. Sure, that's what you wanted to do tonight. So For my shoulder exam, again, I'm testing differential diagnoses, right? So the first thing I'll do, can you move your neck all the way up, all the way down, rotate to the left, rotate to the right. I will kind of position them and load. I don't care the technical aspects of the spurling. Frankly, for me, most of the time, those patients with the 10 out of 10, the lights, they can't move their neck, right? So I already know that this is out of my wheelhouse. We'll load them. They may have axial pain, or some of them actually have true radiculopathy past the elbow. That would be great and classic, but not always. But, we're trying to understand in that moment. You can palpate the C-spine. You can palpate the scapulothoracic joint. But that's kind of my my basic way to rule out neck first. So I do that in 1 minute. I usually don't do a more specific shoulder blade exam. I can show you that in a moment, but I'm usually triaging with neck range of motion and spurling from my history. If that confirms it, I'm kind of good. Then I just make sure my shoulder exam's good. All right. One key thing, I'll always look at the non-involved shoulder first. So that's a rule. For today, we're just going to do one shoulder for interest of time. But I'll always look at that because everybody's native loose jointedness, laxity, and tolerance is different, and I want people to be comfortable. I always tell them I'm going to be more gentle on their involved side. But I'll palpate the key structures to start. So that's the SC joint, rarely a problem. I can march the collarbone to the AC joint. You can kind of feel there's a little divot behind it, so you can get pretty precise 2-finger palpation of your AC joint. Then I'll feel kind of the groove, their biceps groove. So SC, AC, biceps groove, in general, are the things that I'll palpate. I usually stand here so I can both watch their shoulder blade but kind of guide their range of motion. So I'll ask him to bring his arm up in forward flexion, keep going. So again, I'm assessing both for passive and active range of motion. I'm assessing for pain above the horizontal. Then I bring his fingers down to the side. I ask him to kind of bring it down that way slowly. I look for control. I look for a drop arm. All things that might be consistent with impingement, rotator cuff problems, frozen shoulder if they can't do any of that. Then I'll ask him to bring his arm in that way, all the way to the belly, and then out to the side, and then behind his back, right? So we've done active and passive range of motion. We've done all sorts of palpation. We've ruled out neck pathology. We've done all that in about 2 minutes or less, right? Now you can turn to the side. Then I'll start with kind of my strength testing. So I'll kind of go here. I'll ask him to push out to the side. That's external rotation, testing the infraspinatus in general. Push in. That's kind of subscapularis testing amongst other internal rotators. Holding it up to the ceiling in the plane of the scapula. That's testing supraspinatus, right? And then we can get into a couple of special tests. If you're thinking they're an impinger or a cuff, you might just take their arm like this and do a near impingement test. Again, I'm trying to get that shoulder underneath that archway. You can do a Hawkins, bring it across, and do things like that. We can hold him across like this and load the shoulder, looking for pain either in the biceps distribution or deep. That's kind of active compression or O'Brien test. Should be better with the palm up than the palm down, so that doesn't always pan out, right? You can do speeds test, hold this up. This is just a long track sign for the biceps. And that's pretty much our typical battery. In the young athlete, we'll definitely lay them down so that I can stabilize the shoulder blade. If he's laying down, I'll bring his arm into abduction, external rotation, and I'll ask him if he's nervous. Does it feel better with the arm in this position? Or I can bring him to a position where he's kind of nervous. So I'm suspecting he might have dislocated out the front or his subluxes. If I push the shoulder backwards and he's happier, that confirms that diagnosis. Similarly, if I do what's called a load and shift, I put him in this position and push forward. That hurts him or it causes him to be anxious. Guarding of the muscles is also positive. So fear or guarding are two principles in the shoulder that we think about. That would be another suspicion for anterior. I can bring him across the body, reproducing, let's say, that lineman type injury, and load him posteriorly, cross arm. If he has pain in the back of the shoulder, that's more of a posterior labrum. So we don't. Do you? Nice. So we'll do that later. So if you want a car. But I don't do those load and shift, those laying down tests in all of the older patients, because really I just need to tease out neck versus shoulder. Then I need to tease out cuff. impingement versus tear versus other things that are more minor, right? A little bit of arthritis, a little bit of biceps tendonitis. So I used the exam findings to really rule in or out my differential diagnosis for the shoulder. Let me show you briefly the knee, and then we can pause and break. And if you have more questions, I'm happy to stay. Maybe we can jump up here for a second.
You do left or right?
Oh, whichever. Yeah, let's see.
That's good. I think this is up.
So for the knees, just hold on 1 second. So I'm always looking at people. I'm looking at their overall limb alignment, whether they're neutral, bow-legged, or knock-kneed. I'm watching them walk into the room so you can walk. In my clinics, I'm watching them heel walk. You can walk on your heels, and toe walk. Cursory, strength, neurovascular. I tend to look for dynamic movement, so I'm looking at squatting. I get technical with single limb squats. You can do step ups and step down. There's a lot we can do, but in general, just look at their overall alignment and look at their gait. Obviously, someone who can't bear weight, that's after a trauma, is down that first pathway. If they are walking in without a limp, then that's a totally different patient based on the age. So your brain's already going, right, when they're just even walking in the door. You can come on up here and lay back. So again, we always be careful. We don't want to work today.
Great.
So you can slide up in the table. So I always want to move up that way just a touch so that their heels are on the table. I think that's just an easier way to do it. And you always want to be able to walk around your table to examine the non-involved and then the involved ones. So I set up my rooms to do that for efficiency. The key thing that you guys need to do is to look for the effusion, right, as we talked about. So we can look for it and just look at the contour of the kneecap, but we can also put one hand above like this, and that puts all the fluid on the sides of the kneecap, and we can blot and try to feel that. And if you feel a million of these in the course of your life or day, then you'll get used to even subtle effusions, right? The big ones are obvious, and we should always feel those, but even subtle effusions are important, all right? Because a patient with patellofemoral pain syndrome, by definition, has no effusions. So that's different than a patient with the same symptoms and effusions. That's likely chondrosis or someone that had a dislocation previously, now has a cartilage defect. So effusion means almost everything in how I kind of triage a lot of these patients with physical exam. Then I have them tighten the quad, lift it up straight. I definitely want to make sure that we don't miss a quad rupture, patellar tendon rupture. You can hold it straight. You can test their strength. You can actually do, if you have any overlap conditions, do the straight leg that Serena's doing, and you can also rotate the hip. Hip pain is groin pain. There could be referred pain. So if they're locked in internal rotation and they have groin pain with those maneuvers and the knee feels fine through your range of motion arc, there you go, right? That's kind of your exam. So you can do all that in this position, ruling out lumbar spine and hip in 2 seconds, but now we can focus on the knee. Then basically we can bring them up to 90, and at 90 you can sit gently on the foot and tell them you are. The tibia should be in front of the femur. So that's a normal relationship. If that tibia is flush or posterior, you got to start thinking about bad things like PCL tears. Or if it's really posteriorly and sagging, that's PCL plus maybe ACL plus collateral. So you always want the tibia in front. If it's not in front, and we can do our anterior drawer and posterior drawer, and just make sure that relationship is normal. In this position, you can palpate everything, right? So in front of your face, you can see the patella, you can see the quad, you can see the patella tendon, the tibial tubercle, Gerdy's tubercle for the IT band, the fibular head, the perineal nerve, right? We can palpate the entire joint line on the medial side all the way to the back, the entire joint line on the lateral side, the pes and serine tendons over here, distal and medial. So with our hands, we can really differentiate like 20 different diagnoses, all right? Then we kind of come to some of those special tests. So this is what I was saying, pushing valgus, see how it shouldn't open up at all. Whereas if I go to 30, that's her MCL. If I push varus, she doesn't open up at all. If I go to 30, that's her LCL, right? So those are the collateral tests. The ACL tests, the classic ones, are the Walkman. So I kind of stabilize, roll her hip out to the side. I'm using this as my goniometer, so I'm testing anterior translation. That's my Walkman test for the ACL. Pivot shift's a little harder in the clinic, but I'm basically trying to sublux that tibia in this position and then reduce it. So if you have an ACL tear, the tibia is going to be rotated way anterior. When I do this, it's going to clunk. That's your pivot shift. It's really hard. It's more for the operating room, but you can try it and do it. Hers feels totally normal, as it should. So, some of the other tests, so if you have a suspicion for that mid-age person, medial tenderness, they have joint line tenderness, which is pretty specific for meniscus, then I usually kind of lull them when I'm doing this, and I go, boom. I just kind of shock them. If they go like that, that's a meniscus tear. Those patients invariably had some sort of, maybe trivial, but sometimes real trauma. A lot of them are really irritated if they have a positive McMurray. They'll sleep with a pillow between their knees. Their x-rays are going to be normal, but they have pain on a joint line. That's more soft tissue. Those are ones where, you're thinking about if they had an effusion, medial pain, a trauma, they're a laborer, you want to know if that's a true meniscus tear. Some of those might be repairable. So a positive McMurray, to me, if they do that, I'm going to get them better surgically. The arthritics very rarely do that. They'll have a less or no trauma. They will have tenderness, but they won't typically have that real irritated rotatory kind of problem in general. We're speaking in generalizations.
Could you re-demonstrate your McMurrays?
Yeah, I think there's a billion different ways to do it. You can turn them prone and rotate them. For me, I already kind of have a suspicion, and I'm just literally just jolting them, like rotating just from the foot at different levels. Like it's kind of a flexion McMurray. I'm just kind of twisting, taking them through a range of motion arc. If I don't get it, I might go the other way. I'm really just trying to impinge. I'm looking for a mechanical irritant of a meniscus that might be better with my hands. And if I can't elicit a McMurray with twisting, then scopes for meniscus are probably just degenerative meniscus, and probably those patients probably get better without surgery. So in general, all the menisci that come to my office, for the most part, in that middle age group, have that classic story with that very grossly positive McMurray, tenderness on the joint line, and it's really usually like a hangnail that's kind of flipping in and out, and you can really catch it, and that is very uncomfortable and hurts a lot. So you can sit up for me. That's the bulk of that exam. There's a lot of other special tests, but that's the majority of it. So you guys can break. I can stick around. You guys can come up and talk, or we can talk as a group. Whatever works for you. It's late.
Do you have an age limit of what you see, or is it more condition specific? I saw you had some kinks.
Yeah. So in general, most of us we'll see, especially in the kneecap dislocators or the cartilage ones. 13, 14 is our limit here, and then our Pete's colleagues see all the ones that are younger than that. For shoulder, in general, most of us are seeing from the very young, the 13, 14, all the way up till the elderly because of rotator cuff pathology, shoulder replacements, reverse replacements. So that's a much broader net. Whereas in the arthritis, the knee joint world, the wheelhouse for guys like myself in that preservation bucket are really where we're thinking about those realignment surgeries for the active arthritics or injections for those people versus partial replacement. Not necessarily the partial versus total, which is the more sedentary patients that are typically in the jurisdiction of our non-surgeons and our joint replacement team, if that makes sense. Yeah?
When you're talking about the acute traumatic injuries that you think are surgical, you say send them for the MRI. How quickly? Like, is there a certain time that there's going to be less benefit?
I think if they have locked knees, you probably want to get that ASAP. If they're
And what does ASAP mean?
no, I think if they're truly young and have a knee that's like totally locked, we want that within a couple of days,
Okay.
if not sooner. If you have confidence that they're an ACL tear, then that a lot of this goes down to your history and your physical and confidence in your physical. Because if you have pretty good understanding of the problem, then you can start treating it, right? So we won't do the ER thing and put them in a knee immobilizer, tell them never to move their knee or put weight on it forever, which is, we would do the sports medicine thing, which is maybe take blood out, put them in a hinged knee brace, use crutches, start trying to put weight on it as tolerated and range in a very controlled way so that motion's lotion and they start getting activating their quad again. So, the RICE treatments and then kind of, selective motion, which won't hurt any of the diagnoses that we talked about. If you're treating them non-op or even if you're doing pre-rehab, that's how we do it. There's really very few diagnoses besides like actual displaced fractures, things like that, where we're like, oh, let's just calm the soft tissue envelope and then, then we'll go in for surgery. most of the things for us can benefit from getting the swelling down, getting the range of motion back, and getting their muscles activated. But, I think there's nuance there, and I wouldn't expect, the whole group to capture all those nuances. But in general, we're not the group who are going to be knee immobilizer, weight off, and no motion. I mean, that's just like not orthopedic principles. So we're almost never doing that. For a day or two, it's fine until things calm down, get control, get their pain down. Of course, that's fine. But we're talking the week or 2 or 3. I mean, I can't operate on those patients for 6 weeks or 3 months, or I can't do their ACL because they're stiff as a board because of the delayed care. And now, if you do an ACL surgery in a stiff knee, they're going to come out with the stiffest knee forever. So I have to get motion back, and that takes a long time. That sometimes takes a surgery before the ACL surgery. So I see that, unfortunately, a lot with referrals from far away, or just delayed care, or insurance issues, or chronic neglected things all the time. But just for us who are here, I think those principles of kind of just getting control and getting information, and then reasonable protection of range of motion and protection of weight bearing. Patients aren't going to weight bear on something that hurts like hell.
And like the guy with the shoulder injury, like the laborer,
Mhm.
how quickly, with the torn rotator cuff?
Yeah, we'd like to, if we're going to operate on them, we'd like to get to them within the month, or
Okay,
6 weeks or something like that. I think you'd like to get to it sooner, but not like right away. That's not an urgency. Whereas if you have a locked dislocation, that's more of an urgency, right? Yeah.
I was gonna ask, how backed up is the clinic? I haven't had to refer anyone super urgently, but I'm wondering.
Yeah, I think it depends. Everything is challenging until it's not. So if you call the phone room, then maybe it's more challenging. If you text me, they can probably be seen what time is it? 8:05. But that's our urgency in sports medicine. That's what we do, right? I saw a coach tonight. He needs an aspiration and an injection tomorrow morning. He's going to come in between my cases. We're going to do that. We do that for anybody. Just that's his access point, right? So, but I think in general, we're kind of here for you guys to make those access points, or even, frankly, that website I have has a way I get all those referrals on my email. That's not, necessarily just a Stanford thing. That's my own pathway, so I can see that, so I can triage that to our team. And invariably, it's not something that I'll be the expert on, and so I send it to my colleagues or partners, right? People will see my website, and then they'll go to, they'll tell me their history. We know their relative age. You can infer their differential diagnosis and see which of us. Maybe it's a patient best for Serena, or maybe it's a hand patient, or maybe it's a true nerve issue. We can often tell that. The key or the challenge is to educate our our pathways and our phone rooms, and it's not always easy as it's a work in progress, right?
All right.
Yep.
Thank you.
Thanks, guys.
So I just want to say thanks again to Dr. Sherman, Dr. Who's had to leave, but thanks to them for coming. Thank you, all of you, for coming and making this interactive, and hopefully it was helpful. And especially our VBC team, Alicia Wilson, Chelsea Leversedge, Sarah Kemper, and Cindy Gaspar over here in the back have been instrumental in putting this all together. So if we can thank them as well.